Thank you all for coming today. Today is April 11, 2024. We have a special grand rounds today hosted by the Division of Infectious Disease. Dr. Barry Rittmann will be speaking to us today. So to introduce our speaker, let me invite up Dr. Nicole Visicelli from the Transplant Infectious Disease team to come here and give us an introduction of our speaker. Thanks.
Thank you. So it is my absolute pleasure to introduce my colleague and friend, Dr. Barry Rittmann, who is currently Assistant Professor of Medicine for the Division of Infectious Disease, as well as Associate Hospital Epidemiologist. Dr. Rittmann received his medical degree from the Eastern Virginia Medical School and completed his internal medicine residency at West Virginia University. And subsequently, he came to VCU, where he completed his infectious disease fellowship training and completed his public health master's degree. After completion, he was assistant professor of infectious diseases at Eastern Virginia Medical School and the director of infection prevention at Sentara Norfolk Hospital. And in 2022, he returned to VCU, where he is currently assistant professor of medicine here at for the Infectious Disease Division. He is an active member of the Society of Healthcare Epidemiology of America on the research committee and medical co-director of the Virginia Infection Prevention Training Center. His areas of interest include prevention of hospital-associated infections, surgical site infections, antimicrobial stewardship, and infection prevention education. Outside of work, Dr. Rittmann enjoys playing chess and is an avid Philadelphia sports fan, and most importantly, enjoys spending time with his 1-year-old daughter. Without further ado, I would like to invite Dr. Rittmann.
Good afternoon. Thank you all for coming, both in person and virtually. Today, I have been asked to give the topic, top 10 topics in infection prevention that the internist should know. So before I get started, my disclosures, I am the medical co-director of the Virginia Infection Prevention Training Center grant with the Virginia Health Department. This is something that will come up throughout the discussion about some of the resources that we have in case anyone has further interest in learning about infection prevention. I'd like to have a couple of acknowledgements. First of all, my epidemiology mentors during fellowship, Drs. Michelle Dahl, Gonzalo Behrman, and Michael Stevens. And then Dr. Patrick Haggerty was a big influence on me after fellowship. I'd like to thank Laura Peterson, who is our current hospital epidemiology fellow, who has done some work with us in VIPDC, and I've incorporated some of the resources that she's given in our talk. And lastly, I'd like to thank our hospital infection prevention team and our VIPTC team. Both would be too long of a team to list here, but everyone in both of those groups, I would like to thank you for all the work that you continue to do for us. I'd also like to just kind of tell you a little bit about myself before I get into our topics. As you know, many of us have multiple hats in the medical field. For me, first and foremost, I am an infectious disease physician. I won't be talking much about treatment of diseases in this talk. I will really be focusing more on my role as a hospital epidemiologist. I'm also the physician lead of the VCU Health Systems Antimicrobial Stewardship, work in concert with Dr. Sangeeta Sastry, who is our medical center lead, where we make recommendations through our antimicrobial stewardship programs. I kind of think of antimicrobial stewardship as a subset of infection prevention, so I will have a couple of topics that I bring up with that as well during my talk. I am also a clinician educator, both at the bedside, and also I teach a class in our VCU MPH program. So I find education very important, which will come up with my final role, which is the medical co-director of Virginia Infection Prevention Training Center, which I will discuss during our talk. So my objectives for the talk: first, I would like to identify key preventative measures to help reduce the transmission of infectious agents. 2, understand the impact patient care has on the spread of infectious diseases. 3, review the management of high-risk infections in the inpatient setting. And then finally, evaluate potential future advancements in the field of infection prevention. But before I get into my list, I do just want to have a quick primer discussing why we care about infection prevention. Why is it? So many of you may know the saying primum non nocere, which is first do no harm. One of our major tenets in infections and internal medicine in general. Part of our Hippocratic Oath. I would say preventing healthcare infections, causing healthcare infections would be the definition of doing harm to a patient. So if we can prevent these, we would be where this would be one of our primary goals in all of medicine. The CDC survey estimates about 700,000 HAIs in the US acute care hospitals a year, resulting in about 72,000 deaths. To break it down, that's about 1 in 31 patients each day will contract at least one hospital-acquired infection. This has significant impacts on in-hospital mortality, length of stay, and direct annual cost estimates of about $28.4 to $45 billion a year, depending on the source that you look at. So what do we do in infection control and prevention? Infection control is the act of preventing or stopping the spread of pathogens in a healthcare setting. We really use two overarching strategies when we do this. There's your vertical and your horizontal strategies. The vertical is a strategy that targets specific organisms, things like CRE or MRSA surveillance, contact precaution for specific organisms, or vaccine schedules are all considered vertical strategies. Whereas your horizontal strategies are things like that target universal organisms, not just a specific organism. That's things like hand hygiene, antibiotic stewardship, environmental cleaning, removing unnecessary devices, things like that. Here is a kind of just a diagram that we have that kind of highlights both of these. As you can see, if you come up with a vertical strategy at the top, it will target, like for instance, if you do contact isolation for MRSA, that would target people who we know have MRSA infections, whereas hand hygiene will lower the risk of all of these different types of infections. Generally speaking, horizontal infections tend to cost less money and have a longer lasting impact. So whenever I talk about these interventions, I want you to think about, is this horizontal? Is this vertical? We do a bit of both, but generally speaking, horizontal tend to have better effects. So with that, we're going to get into my top 10 list of things to know for infection prevention. And I divided this into really three sets of categories. So the first set of interventions will be our preventative measures that we do. And first and foremost, I never make a top 10 list without having hand hygiene as the number one in infection prevention. So the first thing, if there's anything you take from this talk, I want you to come away thinking hand hygiene is the single most important preventative measure performed within the hospital. Multiple organizations say this, look at CDC guidelines, WHO, Joint Commission, they all consider this the number one impact we do in infection prevention. And it's a simple, easy to do impact that all you have to do is use the machine that we put next to the doors every day. It's a wealth of evidence that it's effective. Despite this, adherence rates are suboptimal. This is WHO's words. I would say abysmal would be the word I would probably use. If you look at world compliance rates, there's a 2018 survey that estimated about 60%. It is a little bit higher in high income versus low income countries, but it's still rarely over 70% and almost never at goal. So here are our numbers that we've been having at our institution. As you can see, prior to COVID, we actually were doing well with a goal of over 80%. We were hitting that goal. Then once COVID hit, the numbers really started to drop. And even post-COVID, we're still seeing the numbers actually continue to decline. A lot of reasons for this. I think some of the reasons is the high staff turnover. But we know that these numbers are really not hitting where we need them to hit. In fact, this actually coincides with a lot of different HAIs, specifically CLABSIs that we've had. So really, again, as you can see, I have right here for people in the audience, these little devices. These are a new hand hygiene technology. If you have not picked it up, please come by North 2 and get yours, because we really are trying to track this better and trying to do what we can to increase this number. Because if we can do this, we're going to see much improved outcomes across the board. Why does hand hygiene work? Well, hand hygiene really affects the transmission of healthcare-associated pathogens. So healthcare workers' hands come into contact with organisms found in patients' room or the inanimate objects around the room. These organisms are then transferred from the surface onto the healthcare workers' hands. And then if they do not perform hand hygiene, they will bring it out of the room. Or if they perform insufficient hand hygiene, they will then contaminate workstations, computers, patients. They can even transfer infections from the patient to themselves based on the zones of infection. If you touch, for instance, cleaning a wound, don't wash your hands afterward, and then you manipulate one of their central lines, you could transfer bacteria from that wound to the line. So it's not just going in and out of the room. There are multiple moments, which I'll highlight in the next slide. I hear a lot of students always say to me, well, I'm not touching anything. I'm just going to go in. I won't do anything. It's fine. Well, if you touch the doorknob, if you touch the curtain as you go in, you touch the wall, remember, it's the environment that's contaminated with these material. So touching anything, including the door to open the room, counts as touching it. So hand hygiene every time, whether a patient's in the room or not, is paramount for preventing these infections. So this is the WHO My 5 Moments of Hand Hygiene. There are really 5 moments that they've identified as key times to wash your hands: before touching a patient, before cleaning aseptic procedures, after touching a patient, after body fluid exposure risk, or after touching patient surroundings. So it's not just going in and out of the door. After you have done something with a patient, you should wash your hands. Really, there's some people make the distinction that after you touch a specific zone and you go to another zone, you should wash your hands in between that. When in doubt, if you're not sure if it's one of these issues, you should wash your hands. It's not going to hurt you to wash your hands extra. It can hurt the patient if you don't. Okay, number 2, special isolation does not replace standard precaution. So this is something that I see come up a lot when I talk with students, learners, even attendings at times. When people are on contact, droplet, or airborne isolations, sometimes some of the basic things that we do kind of fall off. It almost feel like these gowns and gloves have some magical property where once you're wearing them, everything's fine, which is not the case. The gown and gloves are designed to prevent transmission of the bacteria in the room to you, but the PPE itself will become colonized. And as I mentioned, you can transmit from patient to themselves. So if you touch an area that is colonized and then touch a line, you can cause eclampsia even wearing gowns. So hand hygiene is still important. Doing all the other preventative measures are still important. There are multiple studies also that show as the contact precaution rates go up in an environment, the hand hygiene goes down. Once you reach a certain threshold, there's a lot of evidence out there that wearing contact can actually lower your hand hygiene rates. There was a study that came out in 2021, I believe, looking at this. And what they found was once a group had high risk for needing hand hygiene, which was defined as at least 20 opportunities per hour in a patient, the hand hygiene dropped from about 45% down to 37% in the study. So specifically in these high turnover patients who are on contact precautions, we see hand hygiene rates drop significantly. This is a study by Dr. Michelle Dahl. Actually, she did this when I was a fellow, where she looked at proper doffing strategies and alternate doffing strategies to see about contaminating yourself. It's actually a pretty interesting idea. She took some fluorescent coag-negative staph and basically put it on the gown. And as she took it off, she looked to see if this fluorescent bacteria would light up on the person doffing. And what she found was multiple areas that are high risk for contaminating yourself. Specifically, and as you can see on this picture, the hand is of biggest risk, also the neck, the back. These areas are key areas that you do when you're taking off your gowns or taking off your masks. These are the areas that you touch. So it's very easy to spread whatever's in that room to your body, which is why it's so important that you're still following your standard precautions, even when they're in contact, even when they're under other special isolations. There are specific guidelines on how to don and doff. With our VIPTC videos, we do have some training videos if you have time to watch them. They're pretty informative on showing proper technique on how to do that. So I would recommend that in your spare time. Okay. Number 3, understand the risk of indwelling devices and what can be done to mitigate that risk. So this is a picture of a central line. As you can see, it's soiled. The line's being pulled up. It's got 3 lumens. So this line is high risk for developing eclampsia right now, just based on how it is. This should have a replacement of at least the cover. If it's not needed, they should take it out, honestly. But you want to make sure you're doing everything you can to prevent infections and you're taking care of the maintenance of these lines. Having said that, a lot of people like to think of infections as should be a zero event. And there's a lot of pushback on this if you look at some of the literature. This is a commentary by Dr. Michael Edmonds out of Nebraska, or I think he's at West Virginia now, talking about getting to zero, which he describes best as a soundbite, lacks context and is prone to interpretation and manipulation. There's another study by Dr. Behrman, who kind of talks about the same issue. Hospital infection prevention, how much can we prevent and how hard should we try? Again, kind of talks about this getting to zero as a holy grail, which lacks complexity and nuance. It's misleading and is based on an inexact science and suboptimal evidence. And it's unrealistic expectations and outcomes. So trying to push for this zero event really isn't something we should be striving for. What we should be trying to push for are preventable HAIs, which is estimated, depending on the source, about 55 to 70% of HAIs could likely be preventable. But that means you're still going to have some. The more efforts you put into it, the less outcomes you're going to get. So there's a law of diminishing returns. There's also concerns over gaming the system and overdiagnosing to help fudge your numbers. Really what you should be doing is focusing on the evidence that we know that will lower the risk and to get our numbers lower, not to get to zero, but to get to zero preventable infections. In line with that, Shea has released a couple new practice recommendations that they updated in 2022. If you work in an ICU or work in a place that uses central lines frequently or urinary catheters frequently, I strongly recommend you read through these. That way you know what interventions are needed. And if you see anything in your unit happening, you can actually correct that and improve your patient outcomes. At least I would say read through the recommendations. They have some very nice tables and that go over it. I'm not going to go over all of them because there are a lot, but I do want to highlight some of the high yield items that they said that they documented as high value, high evidence. So for CLABSIs, prior to insertion, they recommend bathing ICU patients with chlorhexidine prep daily in the ICU, as well as during insertion prior to implementation, do a antiseptic CHG prep or alcoholic prep, use of ultrasound guidance for catheter insertion, and finally, if possible, subclavian site is preferred. Previously, they used to say IJ is better than femoral, but there's been a lot of pushback on that more recently. But they still believe the IJ subclavian, if it's safe to do, is the preferred site. After insertion, they recommend continuing use chlorhexidine containing dressings in patients on a daily basis. So really one of the big takeaways from CLABSI prevention is the use of CHG dressings or CHG bathing. Things they do not recommend. So use of antimicrobial prophylaxis for short-term or tunnel catheter insertions while catheters are in situ, and replacing CVCs routinely or art lines routinely, unless if there's an active infection going on, you think it's infected, or if you think there's damage, those would be reasons to replace it, but you don't do it based on time. And these are all based on high quality evidence. They also have some moderate quality evidence recommendations. Highly recommend going through these guidelines. Similar vein, they talk about urinary catheter bodies prevention. So strategy they highlight there for insertion, inserting urinary catheters only when necessary and leave in place only as long as indicated, and using appropriate sterile technique. For management, maintaining a closed loop, maintain obstructed urine flow, remind, not just doing it yourself, but reminding nurses, reminding caregivers, reminding patients in transport, always keep the bag below the level of the bladder and keep it from kinking, and always employ excellent good hand hygiene. And then most importantly, they talk about developing a protocol for standardizing diagnosis and management of postoperative urinary retention as an alternative to indwelling urinary catheters. So what they mean by this is bladder scanning, doing intermittent catheterizations. These are tools you can do to reduce the risk of infection. And then they recommend against the use of antimicrobial or antiseptic impregnated catheters or antimicrobial prophylaxis, as these can lead to resistance. Okay, so next section that I'm going to go to is some of our stewardship efforts, both in diagnostic and antimicrobial stewardship. So number 4, when you get a urine culture, blood culture, any kind of culture, know what you're actually culturing, know what the results mean and what they actually don't. very frequently someone gets a positive culture and they assume, oh, we need to treat this. But is that actually the case? So this brings up the term diagnostic stewardship, which I put the definition here, but essentially what that is making sure you're getting tests that are giving you accurate and helpful information to guide patients and not giving you inaccurate information. So really want to make sure when you're ordering a test, there's a reason to get the test. So whenever you get a culture, whether it's a blood culture, a urine culture, a wound culture, which can be divided into deep or superficial, or respiratory culture, you need to ask yourself a few questions. First question I ask whenever I order a culture is, should this culture be sterile? If not, what does that imply about the results? So if you check a superficial wound culture, do you expect that to be sterile? No, it's going to have your skin flora on it. So if you get culture results back that are positive, does that mean there's infection? Not necessarily. So then I would ask the question, is the culture actually useful in this situation? And then if it is, now that's not to say you shouldn't get non-sterile cultures. If someone has clinically symptoms consistent with pneumonia, getting a respiratory culture is still beneficial. But just culturing something for the sake of culturing something can actually lead to causing more harm than good. The second question to ask is, what is the risk of contamination? And if so, what would a contaminated specimen look like? This is really useful in urine cultures. If you have urogenital flora, polymicrobial, this is really consistent with contaminated specimens, especially if it's a clean catch. So you should be thinking about that as you're getting the culture results back. That way, when you see the results, you won't just blindly say this needs to be treated. You should really think conceptually, should this be positive or not? And if it shouldn't be positive, is this a contaminated specimen or what's the risk of that? So blood contamination rates are a huge area of interest. Depending on the source you look at, about 2 to 3% of cultures are considered contaminations. This can really be affected by a lot of things. The number of cultures, the more cultures you get, the more likely you have a contamination. However, if you get multiple at the same time, it can help identify colonization versus true infection. The culture site matters. So if you get a peripheral stick versus from a central line, you will see much higher rates of contamination in central lines by about 2.69 greater likelihood. Catheter tips are probably even worse for contamination rates. We used to use them a lot for diagnosis of CLABSIs. Typically, those aren't really necessary and they can actually cause more harm than good. Usually getting peripheral sticks are enough to help make those diagnoses. And then one of the other big things to focus on is when do you need to repeat culture? There's a lot of new recommendations around this. So obviously, if you're trying to prove that you've cleared a Staph aureus or a Staph logonesis infection, you need to document clearance. Also, if you're worried about endovascular infection, if the patient's not responding to therapy or they're on a salvage regimen for a multi-drug resistant organism, or if they don't have source control, these might be reasons to repeat cultures. But otherwise, generally, you don't necessarily need to repeat cultures. There's a lot of evidence this comes up in gram-negative bacteremias that have come out, which have shown that people with uncomplicated gram-negative bacteremias don't need to document clearance. And repeating those cultures actually can just lead to further confusion. On here is a table of potential elements you can do to reduce, that they looked at that potentially could reduce infections or contaminated specimens. Urine cultures are actually even worse than blood cultures. When I was a med student, one of the first things I learned in med school was, or one of the first things I was told in med school, I should say, is that urine should be sterile. And that's just simply not true. If you look at the data, asymptomatic bacteriuria is a very common occurrence, more prevalent in women, especially elder and postmenopausal women. If you get to the age of 80, about 20% of women will have positive urine, positive bacteria in the urine. So that means any of your patients who come in with ultramental status stroke and you check a urine on them, 1 in 5 will test positive whether they have a UTI or not. It really puts things into perspective when you think about what am I getting with these urine cultures. If they're from a long-term care facility like a nursing home or an LTAC, it's even worse. Up to half of those patients will have positive urine cultures. If they have an indwelling catheter for greater than 2 weeks, about 100% of those will have positive cultures. So what are you really getting out of these urine cultures when you get them? I would argue not a whole lot. If you treat people who have asymptomatic bacteriuria, and by asymptomatic bacteriuria, really the definition is urinary symptoms. Some of the newer guidelines really push back on the idea that ultramental status alone is enough to warrant a urine culture. because they look at people who have treated that and they don't find changes in outcome. They don't find changes in length of stay. They don't find changes in mortality. What they do find is increased rates of antimicrobial resistance and adverse side effects of the urine or of the antibiotic. So really, I would say when you're ordering a urine culture, ask yourself, what's the chance that this is going to be positive, even if it's not an infection? Especially in some of these higher risk patients, the answer is pretty high. So really, you should be asking yourself, do I need this or not when I get this? Does this patient actually have a syndrome consistent with a UTI? All right, number 5, Clostridioides difficile colonization is common, and the treatment of colonization can have negative consequences. Similar to the urine conversation, Clostridioides difficile has pretty high rates of carriage, as high as 18% in hospitalized patients. If you look at long-term care facilities, that rate goes up to over 50%. Recent studies also found that most of these patients have transient carriage, not persistent. So just because they had a negative one in the past doesn't mean you can check it later and then verify that it's true, because it can be transient. There is some evidence that have recently come out that these patients who are carriers can transmit the disease. So doing things like hand hygiene, and really the biggest thing you can do to prevent spread of Clostridioides difficile is practice good antimicrobial stewardship. It really spreads because of decreased the diversity of the gut flora microbiota. So really practicing antibiotic stewardship is really the key intervention to prevent C. diff spread. So who should get tested? Really, you have to have greater than 3 unformed stools in 24 hours, relevant risk factors like antibiotic use, hospitalization, and then lack of alternate reason for diarrhea. So if they're on laxatives, you should stop it. So I have been asked, well, what's the harm? It's PO-vanc, it's not a big deal, right? Why do we not want to, what's the harm in treating these asymptomatic carriers? Well, there's significant issues to deal with. First of all, it's ineffective. And if it's ineffective, it's not very stewardly, as I would say. Second of all, there is potential risk of resistant pathogens. There's a lot of studies out there that look at VRE rates in patients who are on PO vancomycin. And as they go on PO vancomycin, the VRE rates, both in patient colonization and room contamination, go up significantly. Potential adverse reactions to vancomycin is always a concern. One less commonly thought about issue is the premature closure of the diagnosis. So I remember having a very specific consult right out of fellowship about a patient who had diarrhea for about a week. They were on vancomycin the whole time, and they were in the hospital and they're not getting better. They called me in to look at it, and they're on a very high dose of laxatives. We stopped it and they got better. And this person had a week-long hospitalization that could have been avoided if people just didn't see a positive C. diff test and assume that was the issue. And then finally, treating it has been shown to have increased rates of hospital readmission and healthcare costs. How does this, why does this affect patients? Well, oral vancomycin has broad coverage against the GI microbiome. It doesn't just target C. diff, it targets multiple flora in the GI path. So what it does is it reduces that bioburden that I'm talking about. One thing that vancomycin does not target is the dormant C. diff spores. So essentially, you'll destroy any active C. diff along with the microbiome, and then the dormant spores will wake up and then they can take over. And there's evidence that they actually have higher rates of colonization down the line for people who are treated versus people who are untreated. There's actually some evidence also that they have higher rates of active infection, and certainly, as I mentioned, increased rates of VRE colonization and environmental contamination. And there's really no benefit of clearing long-term C. diff in these patients. So I would argue that treating these asymptomatic C. diff patients actually causes more harm than good, which is why we really stress only checking for C. diff if we think they have active disease. Number 6, antibiotic stewardship. Shorter is typically better. So this is a web comic that I've seen on Facebook before, which always makes me cringe a little bit. It seems like a lot of people in the general public seem to enjoy this this kind of myth that finishing your course of antibiotics or not finishing your course of antibiotics can be harmful and lead to resistance. When actually they've looked at this, there's no evidence that this is actually true. It's actually probably the opposite. The more antibiotics you get, the more likely you get resistance. And the fact that we probably prescribe too much antibiotics and too long of antibiotics actually means that stopping it early actually might potentially be benefit. So I wanted to, first of all, just dispel this myth. As funny as this comic is, I think it causes more harm than good. So this is a article by Dr. Spellberg from UCLA, who discusses, entitled "The New Antibiotic Mantra: Shorter is Better." So this talks about the duration of antibiotic recommendations, where they came from. It's not really based on really much of anything other than the fact that the week is 7 days long. So when you get 7 to 14 days, those recommendations come from the fact that the week is 7 days long. He actually calls them Constantine units because the 7-day week was created by Emperor Constantine. So when he talks to his students, he says, we'll treat them with 1 to 2 Constantine units. So not a whole lot of medical evidence behind that. These rates also vary by guidelines. If you look at European guidelines, typically they tend to have a little bit shorter. There's nothing different about the European patients or the European bacteria. It's really because these guidelines are a little bit arbitrary. Overtreatment, as I mentioned, causes significant harm, adverse effects, increased resistant rates. And a lot of the studies that have recently come out have been pretty much showing, in most cases, shorter equals better. As long as you have good source control for an infection. And this is a table in this study, if you that kind of highlights some of the specific studies looking at things like community-acquired pneumonia, nosocomial pneumonia, even pyelonephritis. Traditionally, when I was learning, it was 14 days if you have pyelonephritis, and now a lot of evidence out there shows 7 is probably sufficient. You can do a shorter course. And is it actually 7? Is it 5? It actually could be 5. We don't have specific evidence that points at 7 is the exact day, but we know that people who get 7 days do just as well as people who get 14 days, based on the evidence. This is one of our VIPTC webinars that we did in November of this year by Dr. Spellberg. Highly, highly, highly recommend, if you prescribe antibiotics, which is probably everybody, that you watch this. This is probably one of the most entertaining and informational videos on antibiotic duration that you could get. It's free on our VIPTC website. I would highly recommend going on and looking at it if you have a free hour. I think it will change your prescribing practice just by looking at this. I could not do it justice in the short time that I'm talking about it now. Everybody should watch this video. It's fantastic. Number 7, oral antibiotics are increasingly found to be non-inferior to IV therapy. So this is kind of one of the new frontiers in infection prevention and antimicrobial stewardship. We're finding that more and more the case, we can probably switch to oral antibiotics sooner than leaving people on IV. Obviously, we know intravenous antibiotics are associated with increased cost. They have complications with the catheters, increasing hospital length of stay and even mortality. The bioavailability of many antibiotics are very high. So things like Clinda, Flagyl, doxycycline, Bactrim, all those have excellent bioavailability. So there's really no reason, if they can tolerate oral, to give them IV, assuming normal GI absorption. In many cases, we do IV when really PO would be just as good. It's well known that many of the less severe infections do not require IV. We've known that for a long time. However, traditionally, things like endocarditis, osteomyelitis, bacteremias have thought to require IV therapy. And this has really been challenged recently in a lot of the most recent studies. These are just a handful of them. I could fill up even more, but these are just 4 studies that I wanted to highlight. First of all, I think you probably have all read or at least heard of the POETS trial, which was a New England Journal of Medicine article in 2018 looking at partial oral versus IV antibiotic treatment in endocarditis. There are studies, multiple studies looking at uncomplicated gram-negative bacteremia, which shows that early switch is perfectly safe in these patients. There's even studies out there looking at Staph aureus. That's a little bit more complicated because of source control and because of potential seeding. So that's a little bit more in the weeds to get when you get to it. But there are studies looking at Staph aureus, or this is actually an ongoing trial that they're looking at. That's RCT that's coming out, or it's actively enrolling now. So I'm interested to see the results of this. And then there's even studies looking at it in bone infections as well. So I think as time goes on, as we get some more of these studies come out, you're going to see more and more evidence that shows oral is probably okay in more and more circumstances. And certainly there are certain ones that we should already be heading in that direction. Okay. Final subset of of topics, I will talk about outbreak prevention. So number 8, I wanted to talk about understanding outbreak potential of multi-drug resistant organisms, or MDROs. So MDROs are defined as microorganisms resistant to one or more classes of antimicrobials. Things like MRSA, CREs, ESBLs, carbapenem resistant Acinetobacter baumannii. It's kind of an alphabet soup of your bacteria. These have limited treatment options and have significant concern for hospital transmission. It can be spread from healthcare worker to healthcare worker, contamination of equipment, or even during procedures, we can see these outbreaks happen. When people get these, they have associated with increased mortality, length of stay, and costs. When you see these, you really think, are these all created equal? What are the transmission potential of each infection? Certainly, we want to be doing everything we can in each case to lower it, but you should really be thinking, what are our specific guidelines and what do we do to prevent them? And it really depends on a couple things. As you know, here we do not isolate for MRSA colonization, which is not the case in other hospitals. There's a lot of debate on the best practice for that, which I will say as that is a much larger topic. But the general really comes down to, is this organism endemic or is it an epidemic potential? So things like MRSA, even VRE, these are things that we know are in the hospital. We know hospital providers carry on themselves. I imagine a lot of people here are probably colonized with MRSA right now. So does it make sense to isolate if providers are bringing that in general? Not so much, but if you have something that is an epidemic potential, like carbapenemase resistant infection, these are the ones that you would have epidemic potential, and you need to have specific isolations for as well. You also have to ask colonization versus infection. Just because someone has a positive MDRO doesn't mean they need treatment. It might just mean they need isolation. They need to use increased precautions. When they're colonized, how long do they have to stay on these isolations? Generally, the answer is a long time. We find that people who are colonized tend not to become uncolonized quickly. So usually it's length of stay, even in prolonged hospitalizations. And then you got to think what patients are at risk for this. So these are your critically ill patients, your immunocompromised, burn patients, patients who have recent procedures or surgeries, or anyone in an indwelling catheter. Generally, this means ICU patients, patients who are hospitalized, HEMOC patients, dialysis patients, patients with chronic kidneys, things like that. And then finally, antibiotic exposure, probably the biggest risk factor. If you want to reduce the risk of these outbreaks, limiting your antibiotic use is really it's probably the biggest intervention that we can do. We do specific surveillance for it as well through our antibiogram, but we also even do in certain situations, for instance, with Candida auris, we'll do screening for high-risk populations when they come in. So there's certain things we can do when there's a potential outbreak going on that we can screen to make sure that we are tracking it better. Speaking of Candida auris, I do want to highlight Candida auris as my point number 9, that there is a significant outbreak potential of it. This has been really first described in 2009 in Japan, but when they're looking back at epidemiologic studies and Vitek studies of different strains of Candida, they really found that these cases probably have been around since as early as 1996. So really, Candida auris is a lot more common or has been around a lot longer than we actually think. Even though it's a Candida, we typically think of Candida as typical skin flora. Candida auris really should be treated as its own entity. It is actually acts more like Staph aureus than it does Candida albicans. There's a couple reasons that it's so dangerous. It can grow at higher temperatures. It can accept higher salt burdens, and it is resistant to drying. All of reasons that it can really colonize people's skin, especially those who already have antibiotic exposures and chronic illness, and it can very easily colonize skin because of these factors. As I mentioned, it acts like a bacteria. It's often multi-drug resistant. We actually, in our micro guide, have specific guidelines for treating this because there can potentially be resistant to all 3 classes of antifungals. It persists for extended periods of time on hospital surfaces and environments. We're talking months, 6+ months. Even after resistance to superficial cleaning, we see that it can still be present on studies, and then it can easily be transmitted from person to person. And then once it gets on a sick patient, it doesn't go away. There are studies of people who have been colonized with it, and studies 6 months post, they're still colonized with it. These are just some in-depth studies looking at some of the environmental sampling. One out of Chicago, they looked at 191 samples from the environment after terminal cleaning. And what they found was 38% of these samples still grew Candida auris in their patient area. Specifically, it was found on glucometers, temperature probes, any kind of patient equipment or room equipment is really the areas that it is. There's another study out of Oxford University looking at 70 patients, 63 of which were colonization, who found in 120 environmental samples. It wasn't really on surfaces. Again, it was found on the equipment. So when you have those stethoscopes, you bring your personal stethoscope into a Candida auris room, and you easily can contaminate it. And once it gets on there, even if you clean it, it can be hard to get off of. So it's a significant concern. Last point I wanted to bring up, just especially for those if you end up going somewhere that doesn't have as a robust infection prevention program. Obviously here you can always reach out to us if you have any questions, but if you do it at a smaller university or university that doesn't have, or a hospital that doesn't have infection prevention that is robust, there are a lot of resources out there that you can get. The VDH or whatever state health department you're in should give you multiple options. And if you have any issues, you can always call them and discuss specific cases. CDC, WHO, Joint Commission, they all have their resources, which brings me to our Virginia Infection Preventer Training Center. This is a grant that we've had for several years now, where we are actually creating educational modules to help train people in infection prevention. And we have resources that are available from any level, whether you're a medical student, fellow, nurse, infection preventionist, even we have details for higher up for med executives. And we have information for specialty centers like nursing facilities, dialysis centers, obviously in-cap hospital, pharmacists, ambulatory centers. So we have resources for all of that. So highly recommend visiting this website. As I mentioned, it's a grant, but this is our mission statement. It's a grant-funded program centered to meet the growing needs of healthcare and congregate care facilities in the area of infection prevention and control. Our goal is to work collaboratively with healthcare facilities and public health agencies in order to strengthen infection prevention and control expertise by providing universal IPC training to frontline providers. And education and training of these principles are essential to building capacity in facilities and state agencies in Virginia and beyond. So what do we offer? We have multiple courses. We have a foundational series for people just getting started with infection prevention. We have our intermediate for people who have a little more experience. And then we have our advanced, which is for higher up, a lot of people who are doing more managerial level infection prevention. And there's a table I have here that shows you kind of helps guide you which course is best for you. We also have on-demand catalog. So if there's a specific topic, any of the topic I mentioned today is in here. So we have more in-depth information on all of this. We also do webinars. I mentioned the antibiotic webinar. We also have ones on Candida auris. We have a whole list of webinars that we recommend watching. If there's any topics that you're interested in, we have a CHIPS program, which is our Champions of Healthcare Infection Prevention, which is a way to empower nursing to improve infection prevention at their hospitals. And we have ways to create those through train-the-trainer models. We've created training videos, which we use to help train both patients and physicians and caregivers. And then we also have in-person conferences that we also provide for. These are two of the webinars that I mentioned that I think were two pretty popular webinars that I highly recommend watching if you have time. As far as our training videos, they develop educational videos of infection prevention and control professionals to use, help teach topics at their facility. We use a production company called Rock Creek to help create these. And they're on our website as well as on YouTube. Highly recommend looking at it. We try to make them a little less dry because I know infection prevention can be a pretty dry talk. But we have topics as listed here. I actually would like to show a video, just a short little video on what we, just so you can kind of see what I mean by these training videos. Let's. This is not the presenter, just
Slide.
okay. All right, so we have several videos like that we can we've created about contact precaution and C. diff, things like that. So we highly recommend checking that out if you have time or you need specific training in certain areas. In summary, just kind of go over my 10 points. Hand hygiene, single most important preventative measure performed within the hospital. Special isolation does not replace standard precautions. Understand the risk of indwelling devices. Know what you are culturing, what the results mean, and what they don't mean. Clostridial difficile colonization is common, and treatment of colonization can have negative consequences. Shorter courses of antibiotics are typically better. Consider oral options to complete your antibiotic courses. Understanding the outbreak potential of multi-drug resistant organisms. Appreciate the significance of Candida auris. And then finally, there are resources available for your infection prevention needs. Please visit our website at viptc.vcu.edu for more details on that. With that, I'm happy to take any questions.
Any questions here in the audience?
How's that one? Thank you for your talk. My question is about the stethoscopes in isolation rooms. You know, you nicely put it in your ears and you examine the patient, you leave the room. And you hang the stethoscope up, you leave the room, and then what? What is the rate? Has anyone looked at culturing
Yeah, so
the ears?
that is a concern. I was considering including a part on those disposable stethoscopes. I mean, part of the issue is certainly you can colonize with that. Now, those areas don't come in contact with the patient, but they certainly can come in contact with the area, especially depending on how you hang it. So they certainly can lead to cross-colonization. The key is we don't want high touch areas to then touch patients. So that's why if that is colonized, you're not necessarily rubbing your ears against the next patient you see, but you are touching them with your hands. It's actually one of the big reasons why we have them, because we don't want you to colonize your own stethoscope. I see so often people will just put a glove on their stethoscope, which if you're rotating with me and you're a med student, don't do that, because I'm not going to be happy about that. It's the risk of contaminating your stethoscope and bringing that out is much higher than potentially contaminating your ears. But certainly that is a potential concern. I don't know specific studies looking at rates of that, but just from a biologic standpoint, absolutely that would be a concern.
Anybody else here?
The study we should do is how often does that stethoscope actually help?
Oh, yeah.
Yeah,
Well,
that's,
I can't hear it.
Yeah.
They're useless.
I call them the
Fisher Price.
that's what I call them. I call them Fisher Price my first stethoscope is what I call them.
Yeah, I feel like it just allows us to check the box that you listen, but
Right.
Mhm.
I don't feel like it has ever added to my physical exam.
That's actually one of the reasons why the need for contact isolation is questioned in specific situations, is because it actually can have negative consequences of patient care, both mentally and physically. So
So Barry, I had a question. It was a great talk. I mean, even for those of us who are ID physicians, we don't always get ongoing training in infection prevention, believe it or not, as attendings. But is there any literature or protocols that support, we have these patients who come in who had an ESBL E. coli in their urine in 2019, but they still flag. Do we here at VCU have like a time frame of how far back it goes?
it definitely varies from organism to organism. But generally patients who have had it can remain colonized for months to even years afterwards. Now, obviously part of the risk is those patients who have them for a reason.
Yeah.
Usually they're getting a lot of antibiotics, and if that hasn't changed, they're going to continue to have that same pressure. So that's why generally we do, just because they're at risk for colonizing. Now, there are some ways you can screen people for certain, especially like CREs and things like that, with perirectal swabs. But generally, we know there is a potential risk for it, which is why the flags continue.
Okay.
Question about the AOP, outpatient building. Do you think it is harmful that there is no hand sanitizer stations outside patients' rooms available? So example, none in hallways in the back and none in workrooms. Just curious your thoughts, because I have been concerned about hand hygiene. So I'm not, don't know which specific building you are or area you're asking about, but I would say if you're having area with patient care, they should be available. If not, we can try to look into getting them. Now, I know there's also issues with having a certain amount with fire safety, which is another concern. If you have too many sanitizer stations in an area, then it can be a fire hazard potentially, which sometimes does come up. But generally, I would say they should have hand sanitizer if it's by patient workrooms. Yes. And if you, I can reach out to you afterwards. Maybe we can look into that a little further. And then Stephanie Mayer, I find the contact precaution signs at the VA very small and sufficiently prominent. They're too easily misread, in my opinion. I would welcome bigger, more prominent signs on the door in inpatient rooms. The signs are definitely designed from infection prevention to infection prevent, each individual infection prevention group. We do put a lot of work into how we make them, and if we have new special isolations, we'll make new signs for certain patients. They absolutely can be confusing and easy to miss depending on where they are. I don't work at the VA, so I'm not familiar with the specific signs you're talking about. But if there are concerns, I would potentially, you could bring that up to try to get more visible ones, because that definitely can be we always talk about alert fatigue and the epic boxes. I think on the door, there's the same thing with alert fatigue. If you have, the more signs you have, the more likely people are going to miss them. So.
Any other comments?